Hi, I'm Dr. Simon Freilich, consultant in clinical neurophysiology. Welcome to Nerve Puzzle number 9. This case, as with all previous cases, is purely hypothetical and any resemblance to any individual is purely coincidental. Let's start. We have a 56-year-old lady who is a left-handed zoologist. There is a 5-year history of diabetes for which she is taking metformin, and she is now complaining of cotton wool sensation in her feet and to a lesser extent in her hands. On clinical examination, we have normal muscle bulk, essentially normal tone, power is reduced 4 out of 5 at the toes, otherwise normal, and sensation is reduced circumferentially to pinprick in both the hands and the feet. Let's consider the differential diagnosis here. We've got an older patient with a 5-year history of diabetes, so that puts her at risk of having neuropathy. We have got multiple limbs affected. We've got the feet, both hands, and it seems to be that the feet are more affected than the hands, so there seems to be some length dependency to this process. So the primary differentials here will be a length-dependent neuropathy, possibly a generalised neuropathy. Of course, there are other differentials such as mononeuritis multiplex in these situations, or even plexopathies or radiculopathies, but these are far less common. These would be somewhat out of the box in this particular scenario. Let's have a look at the nerve conduction data and see if we can shed some further light onto what type of neuropathy this patient has. Let's have a look at the nerve conduction tests. So we start with the sensory nerve action potentials, and they are all absent in the feet. And if we have a look at the sensory responses in the hands, for both the median and the ulnar responses bilaterally, they are reduced for age and somewhat impaired. Let's have a look at the motor amplitudes in the upper limbs. We can see here normal amplitudes, normal distal latencies, normal conduction velocities around the elbows, and so there's no evidence of entrapment neuropathies in the upper limbs. If we have a look at the lower limbs, what we can see is that there are small motor amplitudes for both the peroneal EDB motor responses and the tibial AH responses, with no evidence of any significant slowing to account for the symptoms. Let's put this all together now. So we've got absent sensory responses in the feet, we've got reduced sensory responses in the hands, we've got reduced motor responses in the feet, normal motor responses in the hands. In conclusion, we have got a length-dependent sensory motor axonal neuropathy, which is mild to moderate because it's mildly affecting the hands and more moderately affecting the feet. Let's talk through a number of clinical points. The first one is that of length dependency. As nerves are further away from the spinal cord, they taper down and become smaller in diameter, and so they become more susceptible to any pathological processes. Therefore, in a length-dependent process, the nerves in the feet, which are further away than the nerves in the hands and smaller diameter, are picked off first and before them. And so when one's assessing a patient clinically, one tends to find that when pinprick is reduced up to the knee level, then there is clinically sensory impairment in the hands. Of course, we can detect this process far sooner with nerve conduction tests, which are much more sensitive. The next thing I just want to briefly touch upon are large and small fibre neuropathies. With our nerve conduction equipment, we test for large fibre neuropathies. Of course, the difference in size between a large fibre nerve and a small fibre nerve isn't particularly that great. It's just a couple of micrometers really, but we can make an assessment of large fibre function with our nerve conduction equipment. It's much harder to do this with the small fibres, although we do have methods for doing this. You can see a full video explaining how we test small fibre neuropathies by clicking on the iCard above. But coming on to the next point, which is positive and negative symptoms. The large fibres tend to transmit information about proprioception and vibration and position sense, and so when patients have large fibre involvement, large fibre neuropathies, they tend to complain of numbness and weakness. Patients who have got small fibre neuropathies tend to complain of positive symptoms of pain, dysesthesia, burning sensations. And so these are very good clinical pointers as to what type of neuropathy a patient may have, a large fibre neuropathy or a small fibre neuropathy. A final clinical point, just to briefly touch upon, I sometimes come across some misunderstandings about the dorsal columns. The large fibres transmit their signals up the spinal cord via the dorsal columns, and they are not synonymous. Large fibre neuropathies occur in the peripheral nerves, and dorsal column pathology occurs in the spinal cord. So one can't confuse the two of these terms. So if a patient's got a large fibre neuropathy, it does not mean that they've got a dorsal column problem. It's just that their signals are transmitted through the dorsal columns, and if there's a large fibre neuropathy, well, those signals won't get transmitted, or they won't be transmitted as much. But there are two very separate concepts to consider. A couple of neurophysiological points, if I may. The first one is, if there are abnormalities in the studies in the legs, and this is particularly the case for patients who are older, it's vitally important that one doesn't just assess the feet, one actually assesses the upper limbs as well. Really important to get a fuller picture as to what nerve fibres are being affected and to what extent, and what the pattern of the neuropathy is. It's also important as well in patients who have, for example, edema. If patients got edematous ankles, it becomes very difficult to make any form of proper assessment of the sensory nerves in the feet, because the electrodes cannot effectively see the currents being transmitted through the nerves when there's a lot of fluid in between themselves and the actual underlying nerve. And so it's very helpful to have a look at the upper limbs in these scenarios to establish whether or not there's any sensory fibre involvement there, because that will give you a better clue as to what's going on in the feet. It's also very important, particularly for older patients or those patients who perhaps haven't removed any dry skin from their feet, to abrade the skin mildly with something like New Prep. So this is what I use. This is called New Prep. It's a mild abrasive. Put a bit on the skin, wipe it with cotton wool ball, and then any residue I remove with some alcohol starets. I'm not advertising any of these particular products, but just anything similar will do, and it really makes sure that there's a good contact between the surface electrode and the skin and ensures optimal recording conditions. The final point I'd like to make is it can be very useful assessing normality by demonstrating function of the digital plantar nerves. Now, this is very good for proving normality. However, in terms of the specificity when they are absent for a neuropathy is a different story entirely. So I personally think that it's not a very good thing to use to show abnormality, because it can be quite a non-specific finding for a whole variety of reasons. But it's very useful, however, to prove normality when they are actually present. And so thank you very much for watching this video. I hope you found it useful, and if you have done so, please do support this channel by liking, sharing and subscribing. Many thanks, and hope to see you soon in the next video.